At 20 years old, I went into anaphylaxis for the first time in my life. What happened was I ordered a soy latte, and I had no idea that I even had an allergy to soy milk. About 5 minutes after I took my first few sips, my throat just suddenly started to swell. I was coughing, I couldn't breathe, and I had absolutely no idea what was even going on.
When I have an allergic reaction, I start to turn red, and then my throat starts to itch, and I kind of get swollen.
Food allergies, while oftentimes not taken seriously, have become a health crisis in the United States and even around the world.
When 1 in 13 children reporting a food allergy nowadays, it's a pandemic.
Hello, my name is Bailey Portell. I'm 9 years old, and I have a peanut and tree nut allergy.
My name is Zach Slobovic, and I'm allergic to nuts, tree nuts, and I used to be allergic to a couple other things.
My name is Anarys Oquin. I'm 11. I'm allergic to all peanuts, all tree nuts, and shellfish.
My name is Jasper Metta.
I am how many years old?
5.
5 years old.
I am allergic to peanuts, tree nuts, sesame, and egg.
Hi, my name is Aria, and I am 9 years old. I'm allergic to peanuts, tree nuts, soy, wheat, dairy, eggs, sunflower.
Many people are confused as to what the true definition of a food allergy is.
A lot of people tend to say they have food allergies and they don't have food allergies.
It's important to remember that you can experience an adverse reaction to food for reasons other than allergy, such as intolerances or food poisoning.
So again, it's another adverse reaction to a food. Hey, I ate some bad oysters. That's not food allergy, but it's a very uncomfortable feeling, until you heal up. So
food poisoning isn't the only adverse reaction that can cause an uncomfortable feeling.
So I see a lot of adults who are concerned about food allergy every week. And we usually have long conversations about the difference between an allergy and a sensitivity.
I think nowadays there's so many patients that are gluten intolerant or lactose intolerant, and then they get confused between what an allergy is and an intolerance is.
When a statistic like 45% of adults report food allergy, it makes me wonder if there aren't a fair number of those people who have food sensitivities and intolerances that are real, but they're not IgE mediated and they probably don't need an EpiPen. I see a lot of people who are convinced they're allergic to milk. Allergy is a very specific branch of the immune system, and those reactions can lead to severe life-threatening and acute events. Lactose intolerance can make you uncomfortable, but it's not going to kill you.
A lot of people believe that dairy is lactose intolerant, and they really don't understand it. Too often my kids are told that they can just take a pill and then they can eat pizza, or what do you mean you can't eat pizza? Or what do you mean you can't have ice cream?
Many people tend to confuse food allergy with other conditions such as food intolerances. Some people even claim they have a food allergy due to dietary restrictions or simply not liking a food, which can put those with life-threatening food allergies at higher risk.
I read a study, it was like 15-20% of people think they have food allergies. It's not that high.
What is an allergy?
The body is reacting to something that it should perceive as a non-foreign object, as if it's a foreign substance, and so it has a huge immune response to it, and that involves a whole lot of different parts of your immune system.
You probably know someone who has environmental allergies, or maybe you even have them yourself. You might see them sneezing or coughing, especially during pollinating seasons. In some cases, environmental allergies can actually cause a person to react to certain foods.
The oral food allergy or pollen food allergy syndrome, I think it's the more updated term right now. What happens is that there are certain fruits, mostly fruits, there's actually nuts as well and some other foods, that have a protein within them that cross-reacts with a protein in the environment.
For example, someone who is allergic to birch pollen may react when eating an apple. That's because the proteins found in birch pollen are similar to those found in an apple. So if you're allergic to birch pollen and then you take a bite of an apple, your body thinks that you just shoved a handful of pollen into your mouth, causing you to react. You may get an itchy mouth, hives on your lips, or even an itchy throat. The reaction is localized to the mouth and throat area though, because these proteins get denatured once they reach your stomach. So someone who experiences these allergic symptoms when eating foods due to their environmental allergies may actually be able to handle the fruit or vegetable if it's cooked to a certain degree, as the heat denatures these proteins.
So the GI symptoms that people are usually complaining about in terms of upset stomach or bloating or cramping, when you don't have any of the allergy symptoms, is much more likely to be an intolerance as opposed to an oral food allergy.
Now let's talk about food allergies that are not caused by environmental allergy cross-reactions. Let's refer to them as true food allergies, or allergies that are at risk for life-threatening anaphylaxis. Who has a higher chance for developing these true food allergies?
There's a lot of studies to look at that. Obviously, patients who are born with or develop eczema very early on in life, that's the clear risk factor, right? So if you look at specifically food allergies or other allergies, early eczema will be a clear risk factor.
This is a risk factor for babies and young children, but you can actually develop a food allergy at any age, not just in childhood.
You can develop allergies at any point in life. We kind of tend to think that after a certain point they burn out. But it's a sad day in Louisiana when I have to confer a diagnosis of shellfish allergy. It's heartbreaking.
My name is Natalie, and I'm a 24-year-old entrepreneur, fashion lover, and owner of an education company in Los Angeles. I never thought that I would be researching and talking about food allergies for basically my career. But ever since graduating from Northeastern University in 2016, I became allergic to literally everything. At 15 years old, I became allergic to carrots. I would start coughing every time I took just one bite, and my throat would swell up. I continued my life just avoiding carrots until going into anaphylaxis from a soy latte at 20 years old. So I then went on to avoid just carrots and soy milk. But then at 22 years old, I started reacting to everything. I developed severe oral allergy syndrome to basically every single fruit, vegetable, herb, and spice. And then I experienced life-threatening reactions to peanuts, almonds, hazelnuts, soy, carrots, and peaches. At one point, I was down to 5 safe foods, which consisted of pasta, cheese, potatoes, olive oil, and salt. That's what I ate for literally breakfast, lunch, and dinner every single day for like 9 months. I refused to live the rest of my life like this. I started to question, what if our whole approach to this epidemic has been dead wrong? There has to be something I can do, and I have to figure it out fast before I end up in a hospital on an IV due to not being able to eat anything without my throat swelling and experiencing trouble breathing. Many people think that nuts are the only food that can cause a life-threatening allergic reaction. The truth is, there are over 170 foods reported to cause life-threatening allergic reactions. There are 8 foods, though, that account for 90% of all anaphylactic reactions. Let's go through them. First, we have peanuts. Many people think that peanuts are nuts, but in fact, they are legumes. That means that someone who's allergic to peanuts may not be allergic to tree nuts, which includes cashews, walnuts, pistachios, Brazil nuts, almonds. Let's talk about the definition of a nut. A true nut, botanically speaking, is a hard-shelled fruit, which is why they tend to cross-react with many drupes, or pitted fruits, such as peaches and plums. Next, we have wheat, and we're not talking about a gluten intolerance or celiac, we're talking about a life-threatening allergic reaction to wheat. We then have dairy, which includes things like cow's milk, butter, cheese. Next up is eggs, and eggs are often confused with dairy, but they actually have no relation. So someone who is allergic to dairy is not necessarily allergic to eggs, and same with vice versa. Next is soy, which is an interesting one because it has been shown through research that those with life-threatening allergies to soy can actually handle the soy if it is denatured, meaning they should be able to safely eat things like soy lecithin, refined soybean oil, and soy sauce, but 1 drop of soy milk could cause anaphylaxis. The last 2 foods are finned fish and shellfish. Finned fish includes fish such as salmon, while shellfish includes crabs, lobsters, shrimp. It is possible to be allergic to shellfish but not to finned fish, and same with vice versa.
Every allergy to the allergic person is exactly the same. It doesn't matter if it's a peanut or if it's a milk or if it's a sunflower seed.
So what should you do if you suspect that you have a food allergy?
The best thing is to actually see somebody who actually has a past and experience with dealing with food allergies, because it's more complicated than just doing a blood test or a skin test.
There are 2 main ways to conduct a food allergy test. There's a blood test known as the RAS test, and there's a skin test. In a skin skin prick test, a few drops of the diluted allergen is gently pricked on the skin surface using a disposable plastic device. It then takes about 15 minutes to observe if the area turns into a hive or produces redness, indicating a positive result. Although it is typically painless, it is certainly very itchy.
Skin testing does not hurt. It just feels like a little scratch, like you're scratching someone, but no, it does not hurt that bad. It feels like a needle just poking my back and it burns and it itches really bad.
Skin testing hurts a lot. I was screaming and crying when I had it.
Blood tests are about 70% sensitive, we say, so it doesn't always pick up everything. So, a lot of times I'll have patients that will come in and say, I did this blood test and I'm negative, I can eat these things, but every time I eat this thing, I react. And then we'll do a skin test and we'll see a huge reaction. So it's and sometimes it's the other way around. Sometimes the skin test will be negative, but the blood test will show up. And that's a lot more rare, but it does happen occasionally. From what I've seen, the skin tests are more sensitive. And I always tell patients that, the testing that we do, it finds us the suspects, but it's not necessarily the killer. There are testings that have false positives. So we are looking for what could have been the cause, and then using that with history in conjunction together, try to figure out what it is. Because with food allergies, it's very consistent. If you're allergic to a food, you're not going to be able to tolerate the food every time you eat it.
When diagnosed with a new food allergy, most people want to know if eating that food will trigger a life-threatening allergic reaction.
There's no real test to determine the severity of an allergy. I always tell my patients that the biggest predictor of your next reaction is the previous reaction. Whatever happened the last time is most likely what will happen in a future time.
Let's say you've taken both a blood test and a skin test, and they both come back negative for a certain food. At that point, most allergists will suggest an oral food challenge, which is currently known as the gold standard of confirming that you are not allergic to that food.
And the challenge basically is where we introduce the foods in increasing amounts in the office, it's supervised, so that the patients, feel comfortable, and we give them enough that would be in a full serving, and we watch them, and we make sure that there's no reactions that happen. And when the patient passes that challenge, then we feel comfortable saying this food is something you're not allergic to, and you can eat that every day of your life with no problem.
So you can free eat, basically.
Exactly.
Isn't it crazy that a food eaten safely by millions of people, such as a peanut, a glass of soy milk, a chickpea, could potentially kill someone who's allergic? It sounds ridiculous, but this is the reality that we are currently facing with today's food allergy epidemic. A life-threatening allergic reaction is referred to as anaphylaxis. But what is anaphylaxis, and what happens to our bodies during an anaphylactic reaction?
It starts with certain kinds of cells that recognize it, and then other cells that make antibodies, and then the antibodies go and sit on certain kinds of cells called mast cells or basophils, all ready to respond to allergens. And when that happens, they explode open and release these mediators that then act on all different parts of the body, causing different symptoms.
This is what happens on the inside of the body, but what does anaphylaxis look like on the outside?
Skin, they will cause rash, itching, swelling, we call it angioedema, which is like a puffiness. In the respiratory system, they can cause tightening of your throat or itchy, scratchy feeling in your throat. In the lower respiratory system, they cause the smooth muscles to tighten, result in wheezing and trouble breathing. In the cardiovascular system, they cause your blood pressure to drop, which can make you feel lightheaded, can have tunnel vision, you can pass out. In the gastrointestinal system, you have smooth muscles that contract and irritate your bowels, so that causes vomiting, diarrhea, belly pain, intestinal cramping. And then in your nervous system, you can have a feeling of anxiety or what's called a sense of doom. So all of those things relate to these mediators that are being released from these cells in response to what they perceive as a foreign body or foreign agent.
When I have an allergic reaction, I start to go like this, trying to sort of get room. I start throwing up, and I can't get rid of the taste of the food and it always tastes bad.
When I have an allergic reaction, my throat gets really itchy, it is hard for me to breathe, and I get really, really anxious.
My tongue starts to get fat and my cheeks start to get puffy and I can't see things right and I have to take my EpiPen and I have to go to the hospital.
There's a continuum of allergic reactions that aren't anaphylaxis, and some can progress to anaphylaxis and others won't. So an allergic reaction might be something like just rash, or just an upset stomach, or just a runny nose, or a little bit of a tickle in your throat. But in an anaphylactic reaction, really, to qualify as anaphylaxis, you really need a few more criteria, either a constellation of a number of these different mild symptoms, or more serious symptoms like evidence of low blood pressure or evidence of trouble breathing.
There's so many factors that go into an allergic reaction that you really never know what it's going to be. For example, the amount of food that's eaten, the way the food was prepared, environmental allergies if those are acting up, exercise after an allergen is eaten. All of those things can trigger a stronger reaction that, you can't really predict.
What causes someone to react though? Do you have to actually eat the food, or just touch it, or even just smell it?
Airborne reactions are very possible, especially with fish. You hear about it a lot with fish allergies and shellfish allergies. So what you have a reaction to when you're having an allergic reaction, a food allergic reaction, is the proteins. So whenever you have proteins floating around in the air, you can aggravate your mouth, you can aggravate your lungs. So I have seen when you cook shrimp or shellfish, some of those proteins can go into the air.
There are some patients that they can't be in a room where fish is being cooked because they're aerosensitized and they're anaphylactic
They're airborne
there. There are some patients that they can't be in a room where peanuts are being opened.
Touching the foods would not cause any type of allergic reaction. You can take a person who's allergic to peanut and put his hand in peanuts, and there should be no type of allergic reaction. Peanut butter is not an airborne allergen, so touching it won't cause any type of anaphylaxis or any severe allergic reaction.
In a study of individuals with reported airborne reactivity to peanut allergy, if you take those children and you have them do a blinded test smelling a product, what percentage of them react? 0. So, and again, the studies are very limited. The authors of these studies get hate mail from parents who say, why are you trying to kill my child? Every time you make a rule in medicine, somebody breaks it. I'm sure there are kids who react to aerosolized, and I am certain that anxiety plays a role for some people with severe allergy.
If you experience anaphylaxis, no matter what caused it, the only medication proven to be effective is epinephrine.
But again, it's a continuum, it's a spectrum of symptoms, starting with very mild, going to more severe. And if you wait until you have more severe, more classic, recognizable symptoms of anaphylaxis to give epinephrine, you actually may have a harder time getting things under control. You may need more epinephrine than you would have needed had you treated earlier. You have a higher risk of complications, of severe disease, of going on to have what's called a biphasic reaction where you have a second wave. So there are a whole lot of reasons why you want to treat appropriately early, which is challenging because you don't also want to treat something that isn't at risk of progressing.
I'm very good about teaching patients about the use of an EpiPen and always jumping to an EpiPen even if they're feeling slightly like they should use it. Just because it's the only real thing that will prevent a reaction from going really bad.
I always tell my patients, if you think about using it, just use it. It's better that way.
There are good studies that show that patients who got epinephrine prior to arriving to the hospital had a 4 times reduced odds of needing a second dose of epinephrine. I mean, that's pretty striking, which means there's very little I can do as an ER provider to alter the course of things, but people in the community really have that opportunity to change the course of what happens in their allergic reaction if they use epinephrine early. I will tell families that if they're taking a child to the emergency department because they're concerned about an allergic reaction, and they arrive, and as they're walking in, they realize their child has now met criteria for needing epinephrine. Don't think, oh, I'm at the ER, I'll just let them take care of it, because it's going to be 5, 10, 15 minutes before your kid gets in a room, gets a wait-in, gets registered so that a physician can order something, and then for a nurse to draw it up. And that's a lot of wasted time, and potentially time that has an impact on how your child does. So give your child the epinephrine in the parking lot, or just before you walk in the door, and then walk in and say, my child's having an allergic reaction, I just used epinephrine.
What happens is, you know, we've seen in so many different studies that the situations where things get mucky and get bad, and the worst reactions from food allergies are when EpiPens are not used in time or not used at all.
So you pull the blue back off of the EpiPen, you hold your grip like this, and you inject it into the side of your thigh for 3 seconds.
You take off the cap and you press it.
Until it clicks, right?
I can.
There are lots of people who are afraid to use an auto-injector. People have a lot of, sometimes a rational fear of needles. You know, nobody wants to hurt themselves, and that's understandable, and nobody wants to hurt their children. But the reality is epinephrine is the only drug that has been shown to be effective in the management of anaphylaxis, and it is an unbelievably well-suited drug for treating all of those symptoms of anaphylaxis, and does an amazing job and does it amazingly quickly. And the sooner you use it, the more effective it is. So you are less likely to need to use multiple doses of epinephrine, you are less likely to have a long emergency department stay, you are less likely to get admitted to the hospital, you are less likely to have a serious event or death if you use epinephrine early.
If you're having symptoms of an allergic reaction, you might think about taking some Benadryl, as most people do. Not all doctors recommend doing that, though, if you have known anaphylactic food allergies. Some allergists even think it may mask the symptoms of anaphylaxis.
So I don't believe it masks it. There is pretty good evidence that Benadryl does not treat anaphylaxis. So if you are already meeting criteria for anaphylaxis or criteria for giving epinephrine, giving Benadryl is not going to alter that course at all.
If there's anaphylaxis, a person should only be getting epinephrine, for sure. I mean, there is a gray area when a person is having allergic reaction and they only have skin reactions, very slight hives, and then the parents wonder, can we give Benadryl, can we give Zyrtec? It's not going to mask it's not going to mask anaphylaxis. As we said before, it may treat the skin reaction and the hives. The only sign of allergic reaction may be the initial hives. So it may be better not to give the Benadryl or any antihistamine, so you can see how it's developing. Because especially if you have a child 2 to 3 years old and is developing hives, they're not going to tell you my throat is closing or I'm having difficulty breathing. You only see the hives.
There are a couple caveats to using antihistamines in a reaction that you think may progress. One is, if it makes the rash better, you still have to count rash as one of the symptoms. So if you're trying to get a couple minor symptoms to meet criteria, I would still count rash even if the rash looks better. So for example, you had a rash, you took some Benadryl, now the rash is better, but now you're starting to throw up. Well, that's 2 symptoms, so you still count the rash even though it's better. The other is that first generation antihistamines like Benadryl are quite sedating. So if you're going to use them and then you become sleepy, or you're giving them to your child and your child becomes sleepy, that could be mistaken for a sign of anaphylaxis itself.
I'm not a fan of Benadryl during allergic reactions because of the sedatory effects of it. It sedates the kids. And I think that when you do have a reaction like that, you don't want your child sedated or going to sleep.
Most kids respond really well to Benadryl, and really quickly.
Yeah.
And why not? Rather than giving IM injection and go to the ER. But again, I don't know how much. This is what concern. When I hear things like that, it breaks my heart, honestly, because I just feel like that family has been worked up into such an anxious state that them and their child are living in this anxiety-driven state, which just has to lead to to errors in decision making.
Unfortunately, many places don't allow the over-the-counter medications, even when it's on your action plan. So one of the things we really should educate the public about is that, yes, antihistamines are not a cure for anaphylaxis, but if it is on your action plan, then you should have access to it, which is very important. Unfortunately, people do not understand that.
With 15 million people in the United States alone dealing with food allergies, the condition greatly affects our communities.
Too often you hear, I can't go to a baseball game. I can tell you, in my group, we post all the time. People post their experiences, how they go to a baseball game. People say they can't fly. We post how you can fly and how we have flown. We post about how to handle family situations where you don't think you can go to that party because allergens are present, but we post how you can. So it's kind of like counteracting a lot of the fear and a lot of the I can't do because I have food allergies.
Just because those with food allergies may not eat out as often doesn't mean that they save money. People with food allergies spend $25 billion altogether every year managing the condition. A lot of this money is spent on what we call safe foods, which means foods that are safe for a person with certain allergies to consume. There are various companies out there that are free of the top 8 allergens, and while those with food allergies are definitely grateful for them, these companies tend to be a lot more expensive than the average snack company.
I want to show you guys how much more expensive it is to shop for someone who has food allergies. So we're here in Target today, okay, and let's say that I want to buy chocolate chips. So I can go over here, right, and I've got the semi-sweet Nestle, I've got the, mini chips, and if you look at the price, it's $2.69, right, for both the semi-sweet, the morsels. Up here I've got the Ghirardelli chocolate, so I've got milk chocolate, I've got the classic white chocolate chips, right, and if you see the price, they're each $3.14. A little more expensive than Nestle, but not by much, competition. But let's say that I'm allergic to peanuts or tree nuts, or I can't have soy or dairy. I'm gonna have to buy special chocolate chips. That's probably gonna be, for example, which are over here. So if you can see chocolate chips, they say dairy, nut, and soy free. Well, those chocolate chips are $5.19. So we've got the mini chips for $2.69 and the mini chips for $5.19. That's almost double the price just for chocolate that is dairy, nut, and soy free.
Safe foods are just a portion of the $25 billion. There are also skin tests, which are expensive, especially without insurance, and the purchase of EpiPens, which without insurance can cost up to $600 for a 2-pack. And remember, you are not only getting one set, but probably 2 or 3 to keep in different places, and they expire every year.
I think the biggest change in the healthcare industry overall is just an awareness and understanding of how prevalent the diseases are and how much they do affect the lives of the patients. And so we're seeing a much better understanding, and what follows with that is a better level of coverage by the healthcare companies as well. The healthcare system in the way of payers, for example, and insurance companies, I think there have been great strides, for example, recognizing that challenges to be done in clinics are a procedure that is valuable, where that wasn't the case about 5-6 years ago. But I think there clearly is a lack of awareness. The reality is no company, an airline, restaurant, what have you, school, wants anyone to have a severe reaction in their establishment.
Unfortunately, though, reactions do happen everywhere, including schools. I had the honor to connect with Thomas, whose son Elijah passed away too soon at just 3 years old from eating something he was allergic to at school. Thomas now spends his time advocating for food allergies and sharing his story. This video he made garnered so much attention and support on social media, as his message is extremely important.
At 6 months, my son, Elijah Alavi Hafiq Thomas Silvera, we first noticed that he was allergic to strawberries at that age. Then every time we introduced him to something new, We noticed that he's gone allergic to that there have been times that we either take him to the emergency room, in which they treated him for the allergic reaction. Sometimes, it became very worrisome because we had no idea what he was allergic to until we actually done an allergy test on him, which we found out that he was allergic to dairy, definitely allergic to dairy, nuts, shellfish, assorted of fruits from grapes, mulberries, mangoes, you name it, he was allergic to it. So in the times as, with him being born and as he was growing, we had to change our lifestyle. It wasn't just him that was allergic. His older brother was also allergic to many sorts of other foods as well. So my family and I, we had to make a lot of lifestyle changes in terms of eliminating dairy from the home, anything with nuts. We only kept a certain amount of fruits in the house that which both our sons were able to eat, especially Elijah. Elijah was allergic to so many things, so we basically had to become very mindful of where he goes, what he touches, not just in our home, but also in whatever school or daycare that he would attend, or family or friend's house that he was attending as well for a play date. So back in November 3rd, received a phone call from my wife at the hospital, which he was rushed to from the school that he was at. The school that he was in gave him something that he wasn't supposed to eat, which he was definitely allergic to. The sandwich that he was given a sandwich that was a grilled cheese sandwich, which later on had him go into anaphylactics and rushed to the hospital, which he had then passed on from then. Deal with my son Elijah, it is hard for us to not, have him with us, but the important thing is to create the awareness, create the voice of my son to make sure that everyone is aware of the signs and symptoms and get trained, become aware. Go to your websites, wherever it is that you need to go to in order to inform yourself of these symptoms and anything that can definitely be helpful. Because you won't just be saving your child's life, you'll be saving others just for being a part of understanding and knowing the signs and symptoms of anaphylactic and allergic reaction. Thank you.
I don't feel safe at school just because even though it's a rule at my school, people still bring nuts because they just don't understand.
You can say that a school is peanut free, you're lying to yourself.
Yeah.
All you've done is create a false sense of security.
Even though I have a 504 plan, I still sometimes feel scared.
My school is nut aware, but not nut free. I would feel safe, but sometimes I'm just walking around the school and my friend goes, it's like, oh hey Zach, don't go over there, there's a nut. It's just a little uneasy, but what can I do?
I have young children, they pass the food around to each other, so you can't really stop children that way. Children less than 6, 7 years old may not really, they may know they have food allergies, but not exactly are fully aware of them. They could easily share food with someone else. So I think it is important to be nut-free in school.
No, my school is not nut-free. Not even in our class, but when someone sitting next to me has peanuts, my teacher has to move him or her to another table. And at the peanut and tree nut table, they always have a person getting in trouble.
And there's nothing you can do about that. I mean, you're not gonna, so then if you're gonna make a peanut-free school, does that mean peanut allergy kids don't need to have an EpiPen there?
Right. They still do.
They don't need Benadryl?
They still do.
Right, so the system cannot actually, a rule is not gonna create that sort of environment.
Studies have shown that nut-free schools don't reduce the number of allergic reactions, but nut-free classrooms do.
Schools should be nut-free because we have had schools have created this kind of environment where they think if they remove the nuts that they won't have anaphylaxis and that all is well with the world and that the kids most at risk will be kept safe. Many schools switch over to sun butter or to an alternative. There are children that are just as allergic to them. And so there's a catch-22. So with the rise in food allergies, someone's always going to be allergic to something. You can't remove the risk. You have to be prepared, and everyone can be managed with the same management procedures, which is washing hands, not sharing food, wiping surfaces, always having their epinephrine around.
Maybe you might get bullied sometimes or whatever because some people might think you're awkward or whatever because you have allergies, but that's not always like the case.
If a child goes to school, it's like you literally can't sit with us. They sit at a different table. There's a peanut table at school. There's a bullying epidemic in schools with food allergies.
People with food allergies are twice as likely to be bullied than people that don't have a food allergy or don't have another medical disorder.
I was at school on the recess yard, and one of my friends now, wasn't a friend then, but he was like, Zach, eat this. And he was like chasing me around like, eat it, eat it, eat it, eat it. I was just running. A couple of my other friends were like, stop it, and like pushed him away. I was scared. I thought he was actually gonna do something, but he's much taller than me and like bigger and everything.
One of the biggest challenges of having food allergies is the anxiety that comes along with the condition for the child, the parent, or the adult alike.
A couple of kind of teens or preteens every year, they're scared to be in the room with a jar of peanut butter.
Right.
They could not sit comfortably in this room if we had a closed jar of peanut butter right here.
Yeah.
They get anxious, they get sweaty, they get short of breath. They might even break out in a hive.
Oh my gosh.
Because of the anxiety of just having a closed, sealed jar of peanut butter here. Well, those kids have significant consequences of that kind of anxiety when they enter junior high and high school and the rest of life.
The world isn't an easy fix. You go to a playground, there's kids eating goldfish and ice cream. You go to the beach during the summer, there's ice cream on the boardwalk, there's fried dough, there's, millions of types of foods. People are walking around and you're taking your kids on amusement park rides that people just had ice cream, people just had pizza. You can't live your life in the level of fear and limitation that people sometimes project, because it's just not possible. So you have to take the responsibility onto yourself, like say, okay, I know this is going to be around, but what can I do to minimize the risk? So again, carrying wipes, washing hands often, not putting your hands to your face.
I am not a big fan of eliminating peanut from airplanes or pretending that you could somehow create this bubble to follow your child around. And I really, because I've seen the long-term harm of what this anxiety does to the parents and the children, that just accepting that there are things in our life that we can control and things that we can't, and what you are able to control is what you're carrying with you, your attitude. I've learned also, from the support groups, that when a parent is given an EpiPen and say, by the way, the next one may kill you, see ya, that it is an incredibly emotional experience for them.
I'm sure.
And so I try to be very clear with parents that, there's a little bit of fear-mongering that really benefits the pharmaceutical industry to say every reaction could be life-threatening. That's true. But the most common reaction is the same reaction that happened last time. So if your child ate some eggs and broke out with hives on their face, then the most likely reaction is going to be hives on the face with the next reaction.
Another challenge that those with food allergies face is treatment in the emergency room. The one place that is supposed to keep you safe and potentially save your life may not be so trustworthy after all when it comes to the treatment of anaphylaxis.
I think there has been a lack of really good tailored guidance for emergency department providers in how to recognize, not so much recognize something that meets diagnostic criteria for anaphylaxis as recognizing what symptoms are sufficient to warrant treatment with epinephrine. And so there's a real disconnect between care plans that families are receiving for use at home and criteria for the diagnosis of anaphylaxis that are referred to in a lot of guidelines, but were never really designed to guide care for a patient with suspected anaphylaxis who may not yet meet classic definitions. So ER providers have been kind of left with a little bit of a void of good information and to guide them in appropriate care. And I think that has resulted in a lot of variability in the care that's being received in different emergency departments around the country.
I was at Big Bear on a school trip and I had an allergic reaction. The EMTs came and they were like, Zach, calm down, you're just having a panic attack. I wasn't having a panic attack. They had no idea what to do, and they also told my parents that I was having a panic attack. They had no idea until we went to the doctor the next day, and they assessed that it was a reaction, that the EMTs were wrong. It made me feel even more uneasy than I already was.
It is unfortunate that a lot of families are finding themselves in a position where they seem more familiar with anaphylaxis and care guidelines than some of the providers that they're faced with. And I think it's always a really challenging and uncomfortable situation when you are challenging a medical authority.
Managing food allergies is challenging, but it's important to find a good balance.
We have to live our life. We have to teach our children to live a balanced life. We have to go and experience the world, and the reality of a potential reaction is there.
Why are we even experiencing this epidemic in the first place? 50 years ago, food allergies were not as prevalent. Either no one talked about them, or they just didn't exist. Either way, what happened? Is it our fault? The medical community doesn't yet have an answer for us, but there are many theories out there.
A very popular idea is the hygiene hypothesis. That was really developed in the 40s and 50s by a German researcher who identified increased environmental allergy in kids who grew up in cleaner environments, where kids on farms were having less allergy over time.
Hygiene hypothesis, which is we're just way too clean. There's lower incidences of food allergy in, say, Amish populations or populations of children who are raised with farm animals and with dirt and just rub some dirt on it. It doesn't work, it's the wrong kind of dirt. Kind of philosophy where if you shift the, away from a Th2 sort of preponderance of those cells and those allergy cells, then away from that would lead you away more from allergy.
There are considerations about low vitamin D levels maternally. There are, I think what's really neat, kind of compelling right now is maybe an increase in C-sections might be associated with an increase in food allergy as well.
There's got to be probably a genetic component to it. Sometimes you'll see parents that have not just food allergies, but any kind of allergic disorder. So we find that a lot of parents have environmental allergies or asthma or eczema, and then it turns out that their kid has food allergies.
And it's genetics. Genetics plays a huge role in it as well. So I mean, it's just, there's a lot of different factors that go into it. But
right, because there are babies who are born with the allergy. Basically.
Yeah, I mean, and there's parents that will introduce early and they still have a reaction.
Exactly.
And a lot of that has to do with just the fact that they were genetically predisposed to it.
The most part, all the science that's looked into that has been pretty much along the lines of suggesting that vaccines do not play a role in the development of food allergies.
How about GMOs?
Food specifically, there are some people believe that obviously modification to foods and additives to foods could play a role in that, although there's not much scientific evidence to truly back that up, but there are theories along those lines.
I don't think they have anything to do with food allergies.
You don't think they have anything to do with it?
No, I think it's very popular, but there's really no evidence to support it at all. There was a nice article published in the Annals of Allergy that was authored by Dr. Greenhot up at the University of Colorado, and they reviewed about at least 100, more than 100, many articles about GMO foods and allergy, and I think they did a really nice job summarizing that there is no evidence at this point to show allergic ill effects of GMO food.
Another theory is based on the LEAP study, which explored how early introduction affects food allergy.
We are trying so hard to figure out how to prevent food allergies. The biggest thing that has happened probably in the last 5-10 years is the LEAP study. And the LEAP study is Learn Early About Peanut. And it was this really big study in the United Kingdom, and they found that kids in Israel that ate this little snack called bomba, which is pretty much like a little puff snack that's kind of like a Cheeto that just has peanut dust on it instead of cheese dust on it, and it kind of melts in your mouth so you can't choke on it. They found that kids in Israel that ate this snack did not develop peanut allergy.
I think some of the biggest ones, especially recently with the FDA approving, early introduction of peanuts, is that we weren't introducing foods early. We were holding off on a lot of foods thinking that that would prevent food allergy. And we realized we were wrong, that introducing foods early actually is a way of inducing tolerance. And the gut has this permeable membrane that when you would eat these foods early, you would learn that these are normal and these are things that they should tolerate instead of becoming allergic to them.
We've learned now from the LEAP study that we should be trying to get these foods into their diet sooner and keeping them there to reduce the risk of developing the allergy. So it's a real flip.
We've got no reason to believe that that wouldn't work for other allergies. And so that's the reason why the American Academy of Pediatrics has changed all of their teaching and their guidelines to start introducing these allergenic foods a lot earlier.
The most important thing to remember is that mothers are not to blame.
I have parents that come in and they feel really guilty because they feel like, oh, I didn't introduce it early. And I tell them, it's really not your fault, because A, back in the day we weren't introducing early, you were told not to, and B, some of these parents that introduce early are still getting reactions.
So there's a whole lot of things going on, not the least of which has been kind of to blame the mother, and I hate that because until studies come out that prove definitively maternal diet and breastfeeding and what they eat when they breastfeed and what they eat when they're pregnant actually definitively influences food allergy, it's not the best idea to blame the patient or the mother. They're suffering enough. Let's find solutions and let's gather data but actually do something about it.
Gosh, in my first 5 or 10 years here in Colorado, I just met parent after parent with food allergy. They'd be in tears. I think I caused this. The last doctor told me that I caused it because I ate peanut butter while I was pregnant.
They all think it's their fault.
Show me the guy. I'm gonna punch him in the nose. Nobody knows that. We can't prove that, okay? So to throw that out there and put that burden on a mother, especially a brand new mother, is just emotional damage you don't need.
What about people who develop food allergies later on in life, as an adult?
There's a lot of unknowns in regard to adult onset food allergies. We just reviewed this for one of the journals, and there's not much literature, honestly, out there. We know that the foods that tend to develop later on in life, surprisingly, the number one was seafood. You would think it would be nuts, but it was seafood was the number one that developed later on in life. What the majority of the adult onset food allergies, for the most part, seem to be are what we call in the realm of the oral allergy syndrome, meaning it's very common for patients to develop sensitization or an allergy to an aeroallergen, tree pollens, or even dust mite, which then leads to symptoms to eating foods that cross-react with that. So with pollens, that becomes fruits, vegetables, and grains. And interestingly, with dust mite or cockroach allergen, that leads you to develop, some patients to develop symptoms to shellfish later on in life.
Whether you're a parent of a child with food allergies or an adult with food allergies, developing an allergy and learning to manage the condition is challenging and can be scary.
You learn how to cook at home. You learn how to read a menu, you learn how to read labels, you learn how to order specialty foods off of, from the random website, the company, all that stuff. You learn to, appreciate certain grocery stores over the, and then you just adjust.
But certainly there is a commercial need, a medical need for these families who really live in fear.
The public demands that we as practitioners face this and do something about it, because we owe that when we took the oath to our patients to be able to educate ourselves, to learn what we can scientifically, safely, figure out a way that we can help these patients to tolerate their antigens.
The current standard of care is avoidance. Carry an EpiPen. Hope something doesn't happen.
And as I started to really make relationships with these families with food allergies, and I realized how easy it is to diagnose food allergy. It takes a history, maybe a skin test and a lab test.
Yeah.
maybe an hour-long, 2-hour-long visit at the high end. But to live with it for the other 364 and a half days a year, that's the puzzle.
Most food allergies that they develop at a younger age, wheat, milk, soy, or eggs, are usually outgrown around 5-6 years of age.
But what about children who don't outgrow food allergies, or people who develop food allergies as an adult? With today's advanced research, although not yet mainstream, it is actually possible to treat food allergies. Let's talk about treating oral allergy syndrome first, which, remember, are food allergies that are caused by cross reactions to the environment. The way to treat these allergies is to actually build a tolerance to your environmental allergies. You can do this with either allergy shots or SLIT, which stands for sublingual immunotherapy. Allergy shots are given in your physician's office 1 to 3 times per week. Similar to allergy shots, during SLIT, patients are given a very dilute oral dose of the substances or allergens which trigger their allergy symptoms. However, unlike allergy shots, the dose is given in the mouth under the tongue just by spraying it. The dosage of allergens is gradually increased over time, enough to stimulate the immune system but not enough to cause full-blown allergic reactions. With the SLIT treatment, I've been slowly able to add more fruits back to my diet, including oranges, grapes, blueberries, and watermelon. Now let's talk about treatment for anaphylactic food allergies, or true food allergies, those that are not due to cross reactions from the environment. In October 2017, I attended the American College of Allergy, Asthma, and Immunology Physicians Only Conference in Boston. This is a chart that I put together of the different treatments that were discussed that compares the efficiency, safety, and efficacy of each treatment option. The two that we are going to focus on are the peanut patch and oral immunotherapy.
There are a few drugs that are going through the FDA approval process right now for the treatment, for the indication of food allergy treatment. One is a company called DBV, and DBV is the people that make what we call the peanut patch for short. They're also working on a milk patch. They have epicutaneous therapy, meaning that they put a little bit of the protein onto a little patch, like a little sticker that you either wear on the back of your arm or on your back, and the constant exposure of your skin, of the protein through your skin gets absorbed, will hopefully desensitize people to make it so they can actually tolerate the food.
In the initial trials, there were some suggestions that the patch was perhaps better received by some patients, but didn't allow for the level of desensitization that the oral did.
We do know that no one up to this date has had an anaphylactic reaction requiring epinephrine related to the patch. We do know that during a build-up process, we have had anaphylactic reactions for oral immunotherapy. The big difference really is the endpoints. It seems like people can get up to a higher maintenance dose and be able to tolerate more of their allergen after oral immunotherapy compared to the patch. The other big thing is that one is being absorbed through your skin and one's being absorbed through your gut. So one of the thoughts is that, well, when you have an accidental ingestion, you're eating the food. You're getting exposed through your gut.
Let's talk about oral immunotherapy, or what we will refer to as OIT.
It is the process by which you get desensitized, meaning that you start at a really, really low amount and gradually build up and train your body to eat the food that it used to be allergic to. You can do this with multiple foods.
A lot of doctors are doing OIT. They're doing oral immunotherapy, where they're actually giving patients with food allergies these foods in increasing amounts, and the pathophysiology and the mechanism makes complete sense to me.
On the other hand, we see people with really high labs and skin tests who've been afraid of peanuts, and they actually can tolerate a little bit. You know, that's what the OIT protocol is all about. You mentioned parents who are, my child's not a candidate. Well, was that in a discussion with a provider who said they weren't a candidate? Or was that from their personal experience that their child has had such severe reactions or such a sensitivity that they're not a candidate?
And in fact, most of the trials currently are enrolling patients specifically with severe reactions, anaphylaxis, react to very low levels. So I don't think there would be anyone from how severe their allergy is or how high their IgE level is. I don't think that would be an exclusion.
The biggest question that I get from patients is,
or the biggest complaint I get from patients is my IgE is too high. I can't do OIT. I'm not even going to ask. I'm not even going to ask if I am eligible just because my allergist has said I'm, quote, off the charts. My answer is I've never met anybody that has too high of an IgE. In all of our research trials that I've worked on at Stanford, we've a lot of times had minimum IgEs, and a lot of times we've had to do food challenges to prove that you're allergic and that kind of thing, but we've never had a maximum IgE saying you're too allergic.
So far in my experience, every person has been a candidate. I guess there should be a few exceptions. Some people can't be compliant. You know, it's a daily regimen. It's like taking a medicine every day. In the situation of a parent and a child, the parents have to have some responsibility, and the child has to show independent responsibility. If they have poorly controlled asthma, then they're not really a candidate. Now, we can get their asthma under control, and then they can participate, right? And if there are concerns about compliance, or if a person lives in multiple households, then it may not be a good fit for them. But in terms of using the lab results as a barrier, then no.
OIT is not an easy process to go through. It takes a great amount of responsibility to stay on top of your doses and follow the protocol correctly.
The biggest next thing that we have to think about is compliancy, because compliancy, you have to be compliant with your dosing. It is a long process, typically.
Many people don't understand how much work it is. Every day, your child needs to have a stomach full of food and then to add their peanut dose to it. It needs to be at a consistent time of day, and you need to be able to watch them for 1 to 2 hours afterwards. So you can't just say, here's your peanut M&M and send them down the sidewalk to elementary school.
I would sit down with each family and tell them the risks and benefits and discuss what it will allow them to do. Because for some families, allowing them to not have a fear of accidental ingestion would change their life drastically. I'm taking part in a trial for peanut immunotherapy, and I can tell you that it has changed the lives of the families who have participated in it. And for those families, it was definitely very worthwhile.
The results that I've seen look promising, and I think there's a humongous population of people who want to try it.
It's not FDA approved. A lot of people are confused about if it's ever going to be FDA approved. And the truth is that the FDA approves drugs and devices. They don't approve therapy processes. So oral immunotherapy as a process, the process by which you get desensitized, the process of building up from a low amount to gradually increasing amounts, that's never going to be FDA approved because that's a process.
You know, one of the biggest things I've learned by offering OIT in my office is when you open the door to really discuss food allergy with children and their parents, what a significant tax it is on their conscience, on their anxiety levels, on child care, on support networks.
There's about 5,000 allergists in America, and I predict, just from the research that I've done, probably about 100 of them actually offer oral immunotherapy in private practice.
What we offer here is a form of oral immunotherapy, which is a form of treatment that allows a child to become desensitized over time to the foods they were previously allergic to.
And as I looked into it and got the protocol and did this with Luke, about 6 months later, he was 10 years old, I think, 9 years old, I wrote a letter that said, Luke can now move away from the peanut-free table at school.
Wow.
He's still at risk of an allergic reaction, but the risk of a severe reaction is much lower.
Yeah.
The look on his eyes, the sense of satisfaction and self-esteem that moved up multiple notches for him. And I just thought, God, again, I have to relearn what an impact this is on individuals and their families, and how much these little changes can help them live a better life. And I thought, all right, I should do this for more people.
One of the big things about oral immunotherapy is that it doesn't really fit very well into a regular allergist practice.
It's not even they're opposed to it, it's just you have to have the right setup.
Yeah.
I think, you know, the allergists that I know that are doing it are on hospital grounds. You know, they're right by an ER, so that if something happens, they're able to send the patient, you know, to be intubated. I mean, most allergists that I know have not intubated a patient in a long time, and so you don't feel completely comfortable.
Yeah.
And so these are the risks. You don't want to take that risk because it's scary.
Yeah.
You know, if something happens in your office,
it's your liability.
It's your liability.
Yeah.
And nobody wants to take that level of liability on when it's not as well
established yet.
Exactly.
Yeah.
But more so from a scientific standpoint, they weren't taught oral immunotherapy. Most doctors are not taught oral immunotherapy in college, in medical school. It's not taught in nursing schools. It's not taught in PA schools at this point. It's still being researched. A lot of doctors don't feel comfortable doing anything or doing any kind of therapy that they weren't taught in school, that isn't written about in the textbooks with, here's what you do.
There's never no risk.
Right, but I mean, they can...
Because lawyers follow me everywhere, right? But the risk is significantly modified. If your child, I mean, 2 years ago we had a kid in Centennial die from a food allergic reaction to peanut.
Yeah.
He was at the school's bonfire and they were roasting s'mores.
Yeah.
And he got one that was a Reese's peanut butter cup instead of Hershey's chocolate. Didn't have his EpiPen with him, and he died. If he had been on a peanut OIT protocol, who knows for sure, but he would have been eating 1 or 2 peanuts a day anyway.
Yeah.
And that exposure would have been much more like, ooh, I just had some extra peanut, let me get some, I need to get my Benadryl, I need to go, find an adult, I need to get myself in an environment where I can be observed, but it would not have been as severe.
The first food I did OIT with were almonds, and the almonds took about 6 weeks to do, so we started at a very low amount and gradually increased the amount. I now eat 8 almonds every single day to maintain the tolerance, and he actually eats the almonds with me every day, so he eats my dose with me. The second food that I did OIT with was soy, and we used soy milk, and the soy took 5 weeks to do, and we started at super small amounts, 5 milliliters, went up to a bigger syringe, and then to 60 milliliters, for example, and I now drink 6 ounces of soy milk every single day to maintain the tolerance for that. So I can freely eat as many almonds or drink as much soy milk as I want, as long as I maintain that maintenance dose every single day, which will eventually go down to weekly and then monthly. I'm currently now dosing for hazelnut, which comes in these little cups like this, so super small amount, really crumbs at the moment. And the hazelnut will take a little bit longer, it'll take 8 weeks, but I'm very excited to finish that and be able to eat Nutella again.
I encourage allergists to not only not do something that they're not comfortable with, but don't impose opinions that something is bad just because they don't know about it.
I think more people will adopt those practices. And then going to national conventions and having published parameters for guidelines on how to treat, I think people will be adopting that because their practice demands it. Patients are going to demand it.
Everybody needs to have an open mind, and just because you don't know about something doesn't mean that it's the wrong thing to do. And so you can do some research and get multiple opinions.
I'm hoping that it'll become mainstream really soon in the sense that people feel comfortable doing this in outpatient offices where they're not in a hospital.
I have my own private practice up in Redwood City, California, doing oral immunotherapy, and I'm in the process of expanding my clinics nationwide. And I'm doing this for a few reasons, but I'm doing this to help as many food allergic patients as possible. I'm also doing this so allergists, especially allergists that don't feel comfortable, or allergists that either don't want to do oral immunotherapy or can't do immunotherapy because they don't have the time or the space to, just because their practice is already really busy.
Food allergies are found in every age, every gender, every religion, every income level, and in every country around the world. No matter who you are though, it's important to do your own research and educate yourself. Because I did that, I was able to find a solution that worked for me. And I hope that all of you with food allergies are able to find a solution that works for you. If you remember at the beginning of the film, my journey began when I went into anaphylaxis from a soy latte. Although I'm allergic to many other foods, my journey with soy has come full circle as after completing OIT, I am now able to drink soy milk safely again.
Hi there, we're gonna get going for you.
Hi, can I please get a soy latte, tall?
A tall hot soy latte, what else for you?
That's all, thanks.
Perfect, just 405.
Thank you so much.
Have a good one.
Cheers.